4 sessions of systemic pathology. 2 are over, that is half of systemic pathology is over. So now we will be going with kidney, primarily kidney, and a little bit of male genital system where prostate and testicular tumors can come in an exam. And then tomorrow we'll be talking about female genital system and also breast parenchyma, right? So as usual, if you're ready for the game, we are going to follow the same template. We'll go with the basics, then we'll go and see how to structure an exam paper. I'll ask you questions before going into every sheet. We'll continue every sheet, we'll complete every sheet, and then we'll go to the next, right? Sure, Tejas. You mean glomerulonephritis or tubular interstitial nephritis? Fine. So we're ready for the game? Let's start it. Okay. The first and the basic difference is the difference between nephritic and nephrotic syndrome. This is very, very basic. Almost everyone will know it. But as we used to read in our next year batch, I want you to remember conceptually. So I am using this diagram, right? So filtration barrier or the slit diaphragm has 3 layers. We have a fenestrated endothelium, we have a perfect basement membrane, and then we have the foot process, right? Or the podocytes or the visceral epithelial cell, right? So whenever you have any disease which is damaging primarily your glomerular basement membrane, right? Any disease damaging glomerular basement membrane is going to result in your nephritic range proteinuria or nephritic syndrome for that matter, right? If you have any disease which is going to damage or destroy the food process, it is going to result in your nephrotic syndrome. That is the basic difference. I want you guys to remember it so that you don't ever have a confusion of which will cause nephritic syndrome, which will cause nephrotic syndrome. The logic behind this is very, very simple. Endothelium is fenestrated, right? Your podocyte is also has gaps. It also is fenestrated, right? It also has gaps. So the only person who's separating the blood and the urine is the basement membrane. So whenever there's a basement membrane rupture, RBCs can easily leak outside and cause hematuria. As simple as that, right? But whenever I have a podocyte damage or podocyte injury, what will happen? The charge and the of the GBM will change. Charge and the pore size is the one which filters your protein. When the charge and the pore size changes, the protein, the bigger protein like albumin start leaking. That's why we have a classical case of a nephrotic range proteinuria, right? So, and I have 2 reasoning why questions. If anyone can answer that, do let me know. Can anyone tell me why there is chance of increased thrombosis in case of nephrotic syndrome? It's the first reasoning by question. I'll ask you the second one also. I want to guess who is online. Attempt and try to comment on it, right? The second question what I have is, why do patients with nephrotic syndrome have iron refractory iron deficiency anemia? Which means they have IDA and we give iron as an oral tablets, it will not work for them. What is the reason? These are 2 reasoning why questions with respect to nephrotic syndrome which can come, right? Aishi, if you have done with your routine, start the FARRE and start revising early. Doing it early never affects us, right? Okay. Hyperlipidemia is different, right? I asked a question, why do we have thrombosis? Hyperlipidemia is different because of lipid urea, right? So the answer is simple. Antithrombin 3 will be lost in nephrotic syndrome in addition to the plasma proteins, albumin and everything. Because antithrombin 3 is an anticoagulant, because of loss of the antithrombin 3, there will be an hypercoagulable state. This is classically seen in case of a nephrotic syndrome. Do remember. These are few rare proteins which are lost. We always know albumin. That's something which you'll never forget. We'll never forget lipid being lost. So you'll have hyperlipidemia like you guys said. But these are 2 proteins in addition to the routine which will be lost. Other one is transferrin. Definitely there is, right? So transferrin will be lost in case of nephrotic syndrome. The moment transferrin is lost, you end up in having an iron deficiency anemia, which is iron refractory. Because even when you give oral iron or parenteral iron for that matter, I need transferrin to take them to the bone marrow, right? So there are 2 reasoning why questions. Why nephrotic syndrome can have an iron refractory iron deficiency anemia and why nephrotic syndrome can have hypercoagulable state or thrombosis, right? Perfect. Now let's go to the basic difference between nephritic and nephrotic syndrome. An easy question for you guys to answer. I want you guys to answer. Tell me which syndrome of these, nephritic or nephrotic, will have hypertension? Which will have hypertension? Tell me which will have hematuria. Next question is, tell me which will have selective proteinuria and edema. You know the answer, right? Again, I want to build a concept here rather than just memorizing. Here I have a GBM rupture. The moment the basement membrane ruptures, RBC goes outside, the pressure also will be lost, right? It's like in a tube, I am having a hole. So obviously to maintain that pressure, my body will have a reflex mechanism of increasing the blood pressure. That is hypertension, right? So nephritic cause nephrotic, it's simple. This part, I don't want you to write in the exam. It's just for understanding. If you have any viva or any stuck, which disease nephritic, you can easily come back to it, right? You will have hematuria in nephritic syndrome. You will have definitely proteinuria in nephritic syndrome also. It will be mild in the range of 1 to 2 gram per day. It's not deciliter. Please remember, this unit is very, very important. It's per day loss. Okay, and it's non-selective, which means albumin, globulin, everything will go out. Edema will be there here also. I'm not denying it, because kidney is getting failed, right? Renal failure, kidney being affected, edema will definitely be there in both, but obviously more predominant in case of nephrotic syndrome. You will have hypertension. Like I said, there is a leak, compensatory hypertension, right? Azotemia, oliguria. These are symptoms of renal failure. Renal failure might be a possibility in nephrotic syndrome, not always, right? Nephrotic syndrome does not always present with renal failure, but they can present with renal failure, right? Now tell me, nephrotic syndrome, hematuria present or absent, plus or minus for the first one? Never. You will never have hematuria in case of nephrotic syndrome. Will you have proteinuria? Yes, obviously. More than 3.5 grams per day. Again, the unit is per day proteinuria. This is definitely a massive proteinuria. Not just that, it's also a selective proteinuria. Who's getting selected here? It is albuminuria primarily. Apart from losing albumin, I told few rare things, the antithrombin 3, your transferrin. In addition to that, you will also have lipiduria. Because lipid is lost, what will my body try to do? My body will try to compensate that lipid loss, which will result in hyperlipidemia. I'm having loss of albumin. Is there any way I'll have edema? Albumin loss, can anyone tell me how does it cause edema? By altering one of the important pressure. Edema will definitely be there because of alteration or loss of the oncotic pressure, right? One more question. Can anyone tell me which part of the body you will have renal related edema? Be it nephrotic, kidney failure, anything. Which part of the body? Is it the tummy? Is it the foot? Which part of the body, right? Hypertension will not be primarily there. Again here, it's plus or minus. It's based on the disease. If you have a patient with FSGS, that also is primarily nephrotic syndrome, right? You will have kidney failure, you will have azotemia, you will have oliguria, right? It's plus or minus based on the extent and the intensity of the disease, you will have it, right? Perfect. What did I asked you a question? Can anyone answer that? Perfect. The edema will generally be a facial edema. It'll be periorbital puffiness or a facial edema. Both are right enough, good enough for you. And if anyone asks you why there is a facial edema, there's an answer for that also. Here, the loss of oncotic pressure is not a very important factor. Increased hydrostatic pressure in Frank Starling is the dominant factor. This is not a dominant factor. So these places, if you touch, it's very loose. It's a loose connective tissue, so it's easy to percolate the edema fluid even if the pressure is less. That's the reason periorbital puffiness comes first in case of a nephrotic syndrome or in case of a renal related edema, right? Perfect. So this sums up the first part. We have laid the difference between nephrotic syndrome. Why this is important is, whenever we read any glomerulonephritis, in an exam, you need a heading of clinical features. I will tell nephrotic syndrome. I want you to write everything what you read here. Nephrotic syndrome, write everything what we read here. So this is a common clinical feature for every glomerulonephritis. There are only two things, either nephrotic or nephrotic syndrome, and you can write. You already have something which is very certain to write in an exam paper, right? Now let's go to glomerulonephritis, right? One by one. The first guy is membranous glomerulopathy. Glomerulopathy is a better term than glomerulonephritis, but it's fine. If they say glomerulonephritis, it's okay, right? The same thing only, right? So in membranous glomerulopathy, there are two things. One is primary. Predominant of the membranous glomerulopathy, or MGN, that also is a known abbreviation, is primary. It's antibody production against PLA2R, which is phospholipase A2 receptor antibody production, right? Secondary can have, drugs can cause it, SLE can cause it, hepatitis can cause it, lots of them can cause it, right? Infection, drugs, and autoimmune disorders can cause it. Secondary glomerulonephritis, less common in incidence, right? Approximately 10 to 15%, right? Approximately 10 to 15%. So what happens is, when I have an antibody to PLA2R receptor, right? the antibody goes and binds to the antigen. Where are these antigen? The antigens are on the podocytes. That's a location of the normal antigen. You, me, everyone in the world has, let's assume this is my podocytes, the finger-like projections. This is how we have the antibody. Antigen of PLA2R, phospholipase A2 receptor. The antibody goes and binds to it. Antigen-antibody reaction happens. Who gets destroyed? Podocytes gets destroyed because they are on the podocytes, right? The moment podocyte goes away, nephritic or nephrotic, I want everyone to comment. We know it because once we know the pathogenesis, the next clinical features is automatically a loop. You go into a loop, you will never ever make a mistake, right? By default, it will alter my filtration barrier. It will cause protein leak. It causes nephrotic range proteinuria. Okay, when you go to medicine, you will read that membranous glomerulonephritis can present with nephrotic as well as nephritic. I am not denying that. 85 to 90% of them will present with nephrotic range only. So for a second year student, you will stick to nephrotic. The moment you finish MBBS, you might differ. MD, you might differ more. DM, you might differ more, right? That is a range group, right? Here, 85 to 90% of them will present with classical case of nephrotic syndrome. You will write every feature what we studied here. Easily 2-3 lines, sorted. Age, alter. It's generally in adults, can have a wide age range group, but generally in an adult, right? Now, we know the clinical feature. Then, microscopy. One of the most important things you should never forget in kidney and glomerulonephritis, talk about immunofluorescence and electron microscopy. Fine, perfect. Now, in light microscopy, why did we even name them membranous? Because the glomerular capillary look like a thick membrane. That's all. It's simple. These are antibody, right? Binding to an antigen. Can I call antibody a protein? They are protein. What is the color of protein? Pink color. So normal glomeruli is also pink color. This is extra pink color. So what happens is my capillary becomes more thick. That's all. It becomes a thick pink color. I should have used a pink color. Okay. It becomes a thick pink lining, thick pink lining, thick pink lining. That's all. Thickened glomerular capillary loops. A pattern look like a membrane. So we call it membranous glomerulonephritis. Before the advent of immunofluorescence, we were using a stain called silver stain, which are basically Jones stain is the name, which is basically a silver stain, right? We have Wharton Starry, we read in the H. pylori, right? Like that, we have Jones stain. Here we have an appearance called spike and dome appearance. Just remember the name. It's spike and dome appearance. It looks very, very tiny, bit difficult to do and bit difficult to interpret. But it is a very important point I want you to write in the exam. Ultimately, my diagnosis is going to be based on immunofluorescence. Let's use the hematology concept what we learned. This is an autoimmune disorder. How many of you will agree it? It's an autoimmune disorder, right? Perfect. Right? Any autoimmune disorder in the body, is it acute or chronic? Tell me. I'll go with very simple knowledge which you used in your 11th standard, 12th standard. We'll redefine medicine in the way what we think. It is chronic by default. If it is a chronic autoimmune disorder, the most common antibody will be IgM or IgG. All the best, Anushka. It has to be IgG, right? So what I'm going to see here is I will have IgG deposit in every place wherever I saw the antigen here. If I see the antigen, all the places I'll have antibody deposited. And the antigen is not continuous, it is intermittent. So what I'll have is a staining pattern called as granular staining pattern, right? You'll have IgG granular along the capillary wall. It will be like dots. It will be like dots of green color, and in every immunofluorescence, green color is positive. That's all. Fine. It's IgG deposit. For any autoimmune disorder, it's going to be IgG only. Remember that. Fine. Perfect. Done. Now we know immunofluorescence as well. Now electron microscopy. Electron microscopy, again I go back to the pathogenesis. I had antibody in the podocytes, right? Just below the podocyte. Podocyte is epithelium. So I'll have deposit in the subepithelial space. Because podocyte is epithelium, right? So uniform subpodocytic deposits or subepithelial deposit is diagnostic. The word uniform is very, very important because wherever I have the antigen, all the places antibody will bind and that causes the deposit, right? Perfect. Done. Okay. Treatment, I will leave it to you. Mostly immunosuppression. If you have read in your pharmacology a little bit more about it, write that. And always treat the primary cause. If there is a secondary pattern, treating the primary cause is by default important. Drug is causing, stop the drug. Infection is causing, treat the infection. Automatically come into play, right? I'm just zooming out. Etiology we'll learn, pathogenesis we will learn. We'll take the clinical features from nephritic, nephrotic, light microscopy, immunofluorescence, electron microscopy. Sorted. Done. Can we move to the next? The next guy is Goodpasture. I'll zoom this. I'll ask questions. Be ready to answer them. Right? Very simple questions. Can anyone tell me which antigen has which antibody we'll have in Goodpasture syndrome? Antibody against what? That's a classical finding in Goodpasture. That's first. Do you remember Goodpasture syndrome whether it's nephritic or nephrotic range proteinuria? Yes, no, maybe. That's the second question. Hi, Mariam. Good evening. Third question. You only told that you have an antibody production. So can I say it also is an autoimmune disorder? Yes. If so, the most common antibody here also is IgM or IgG? Perfect. Sorted. Life is simple if you know the basics. That's all. Right? Perfect. Now, let's take whatever input you gave and we'll rethink the way what we read glomerulonephritis so that it's easy for us to write it. Goodpasture syndrome or anti-GBM glomerulonephritis. These are two different things. See what they are asking. These are two different things. Goodpasture is a syndrome, which means kidney alone is not affected. Anti-GBM glomerulonephritis is kidney only affected disease. It's a part of the spectrum, right? Like I said, I'm going to have antibody against collagen 4. Some of you said collagen 4 is on the GBM. So what I have here is antibodies against GBM. GBM is destroyed. Remember the first slide. You'll always have nephritic syndrome because the barrier is gone. RBC will leak outside. It presents with classical nephritic syndrome. Close to 100% of them will present nephritic range proteinuria only. Write the clinical feature of nephritic syndrome as simple as that. The only difference, in addition to the nephritic syndrome, what I want you to write is this. If it's only kidney involvement, I call it anti-GBM glomerulonephritis. If kidney is involved and lungs are involved, how do I know lungs are involved? There might be history of hemoptysis. If this in the question hemoptysis or you examine the patient where there's lung problem, the X-ray or something of the sort, right? Hemoptysis involvement, lung involvement plus kidney involvement, only then I can use the term Goodpasture syndrome. Otherwise, it's just anti-GBM glomerulonephritis, right? Perfect. Now here also I have antibody on the membrane, on the capillary wall. So what will be the light microscopy? Same thing, thick capillary loop. You'll have very thick capillary loop, almost similar to your membranous glomerulonephritis. It will not differ at all. The main thing it will differ here is, this is collagen, GBM. This was my food process. And here what I have antibody here, right? The Y-shaped antibody lining here. It is not like PLA2R. It is not intermittent. It is continuous. So what will be the immunofluorescence? Linear or granular? Tell me. Kaleem, Kalpana, Sohana, Falak, Hema, everyone. It will be absolutely linear because the antigen is linear. The antibody bound to that is linear. The immunofluorescence, what I do will be linear, right? So you'll have linear. This is very important. Remember this. This can be a Viva. This can be an MCQ question because this is the only glomerulonephritis which will have linear positivity. Linear, again you said in the first itself, it is IgG. It cannot be anything. Linear IgG positivity along the capillary wall is diagnostic of your Goodpasture syndrome. Immunofluorescence or electron microscopy, generally it's negative. You won't see deposits much. We are still contemplating why deposits are not seen much. Don't write no deposits because it can be present, may not be present. Just ignore immunofluorescence. You don't see them here. Treatment here is same. It's an autoimmune disorder. I do the same thing, immunosuppression. Okay. And one important thing, I'll give you an extra clue on how to make it lengthy, right? Complication. Now tell me, this is both for MGN as well as Goodpasture syndrome. Can I say both MGN as well as Goodpasture syndrome, can they go to an extreme complication of RPGN or crescentic glomerulonephritis? Yes, no, maybe. Hi, Shravel. Go back to your 9th. Come back soon after 3 years. It will. RPGN is a complication of almost every glomerulonephritis. You can write them. It's an acute exacerbation of your glomerulonephritis. That's all, which is sudden onset renal failure. Okay, except minimal change disease. Except minimal change disease, almost everything will become RPGN. You can write. It's an extra heading. You already know that. I'm just giving a structure to the question, right? We'll zoom out. Simple. Etiology, pathogenesis, clinical features of nephrotic syndrome. Write every single point you know about that. Write the distinction between anti-GBM glomerulonephritis and Goodpasture syndrome. Light microscopy, immunofluorescence, don't want electron, treatment is immunosuppression, and you have a complication of RPGN. As simple as that. Clear? Any doubt? Do let me know before we go to the next guy. Next guy is one of the favorite for second year students. Most of your internals must have had this question without fail, right? If there is a history of a streptococcal infection, after that the kid had cola colored urine, what is the diagnosis? After that couple of weeks, cola colored urine, what's the diagnosis? Tooth fairy, we are doing FARRE. This should be enough for it. There are multiple sessions. Please follow them. It is undoubtedly PSGN, Post-Streptococcal Glomerulonephritis or Post-Infectious Glomerulonephritis, right? Very, very, very classical one. You have to remember this, right? Post-Streptococcal or Post-Infectious. It's either PSGN or PIGN. Both means one and the same. If there's a question saying write a short note on PIGN, please don't think it's something different. It is post-streptococcal instead of that post-infectious, because staphylococcus also can cause the problem. So post-infectious is a better term, right? So what happens here? You have a streptococcal infection. It could be skin infection. It could be throat infection. It doesn't matter. It needs to be nephrotogenic strain of streptococci. That's all. When you have the infection, there will be circulating antigens of the streptococci in your serum or the blood. That will get planted on the glomerulus. The moment it's getting planted, it will not destroy it because an antigen getting planted, that's all, right? So who will come and destroy? Your immune response will be there to that. And that immune response is the one which will destroy it, and that immune response takes a lag time of 1 to 3 weeks. This immune response is going to cause glomerular damage. Okay? That is the reason we have nephritic syndrome. In other words, cola colored urine or hematuria. There's a very important distinction here. You can see the clinical correlation there. URI, a lag time of 2 weeks. Hematuria, my diagnosis, PSGN. URI, the second day you have hematuria, my diagnosis, IgA nephropathy. Is there any other name for IgA nephropathy? If you guys know that, do comment on that. The time duration between the upper respiratory tract infection and the hematuria matters. It's very, very important. One has a lag time, one does not have a lag time. Fine. Okay. This is a very classical case of nephritic syndrome. Few things about PSGN. This is one of the most common cause of nephritic syndrome in children. I'm not saying it will not affect the adults. Yes, it might involve the adults as well, but in children it's very, very, very common, right? Second, you don't want a biopsy to diagnose PSGN. You can diagnose clinically with one serological test. Diagnosis just purely clinical plus one serological test. Can anyone tell me what is the serological test we use to diagnose PSGN? No takers for the other question. The other name for IgA nephropathy is, I thought you guys must have known that, called as Berger's disease. Okay, that's the other name for IgA nephropathy. Yes, Sahana, you're right. Okay, you need one serological test. What is that? That is identifying the complement levels. Can anyone at least tell me this? What will happen to the complement levels? In particular, C3 levels in case of PSGN. Will it elevate or will it reduce? ASO will not help you, Dharmishta, because 3 weeks now. And ASO is not specific for kidney. You can have ASO data even in rheumatic heart disease, right? What will happen to C3 levels? It will reduce. Serum complement fall with a classical clinical history of streptococci in the past and hematuria is almost diagnostic of PSGN, right? The only thing, biopsy is required only for atypical presentation. Only in atypical presentation, we take biopsies. These are questions for Viva which can come. So I'm telling that you need not mention that in the exam for a theory question. When I have renal failure, when there is no lag time, I'm suspecting IgA, then I'll take it. When there is nephrotic range proteinuria, right? But history of streptococcus, then I'll take it, right? Any atypical presentation, I need a biopsy. Otherwise, biopsy is not required to diagnose at all, right? Now, we know the etiology. What will be the pathogenesis? A simple pathogenesis. You have a streptococcal antigen, it's getting deposited in the glomeruli. Streptococcal antigen can get deposited anywhere in the glomeruli. It can get deposited in the food process, on the GBM, or in the endothelium, subendothelial space, even in the tubules. But the most common is subepithelial space. That's the most common place where it can get deposited. The moment a bacterial antigen gets deposited anywhere in my body will create a response. It will create an antibody. It will activate classical complement pathway. That's how my immune system works, right? The moment classical complement pathway is activated, I'll have C5A, I'll have C3A. Can I say C5A is a very powerful chemoattractant from general pathology? It is very powerful. So what it's going to do is, it is going to attract the WBC from the lumen to the subepithelial space. Should diabetes happen? They should happen. If diabetes happen, will they destroy the GBM? Absolutely yes. So I'll see you next year. Yes, so this will damage the GBM. The moment GBM is damaged, nephritic or nephrotic range proteinuria. Undoubtedly, nephritic syndrome, nephritic range proteinuria by default. Fine, perfect. Now, I want you to answer this question. This could be a reasoning why. I have answered here, IgG is more than IgM. Why? It's a post-streptococcal glomerulonephritis, bacterial infection. For any bacterial infection, what do we think of? We always think of IgM. Why is IgG more important than IgM? The same finding will be seen in immunofluorescence also. Why IgG more than IgM? This is very important. It's simple. The reason is, again, it's not an acute problem. It's a lag time of 1 to 3 weeks. In the throat or in the skin, I would have had IgM that time. After 3 weeks, obviously it is late. It's delayed, right? It will become IgG only without fail, right? It is by default later one. Later presentation of streptococcus, not an acute manifestation of streptococcus. Fine. Please remember that. Perfect. And because complement is being activated, every single glomeruli in the kidney will have complement deposit. Because of that, your serum C3 will be reduced. That's an evidence. When I take a serum C3 when it's reduced, I'm indirectly saying the kidney is affected because of the complement damage. So it is a PSGN. That's all, right? Perfect. So we know the pathogenesis. Light microscopy. You only talked about the pathogenesis. No, I'm having a powerful chemoattractant. So what will you see in light microscopy? You will see the same guy. You will see the most important finding is this. Increased WBCs inside the capillary. That's also called as an endocapillary hypercellularity. Or there's one more term called as an diffuse proliferative glomerulonephritis. Anywhere you see diffuse proliferative glomerulonephritis or WBCs, WBC is equal to bacteria. In the capillary, you think of a PSGN. This finding is an extra finding. Obviously, when the proteins are getting deposited, I'll have a thicker loop. It's a non-specific finding. Robbins actually talks about one more finding. Robbins tells you how to make the exam paper bigger. They will tell that glomerular size will be increased. See, beautiful, na? 100 neutrophil comes inside, obviously it will become bigger. Increase in the glomerular side, thicken loop of the capillary. The most important thing is endocapillary hypercellularity or increase in neutrophils in the glomerulus. Very, very important. Next, a granular deposit. Everything is granular except for Goodpasture syndrome of IgG, IgM, C3. The most important thing here is this guy. Don't miss that. It has to be C3. C3 is very, very important. Others are okay for me. C3 deposit, and it has been given a name, starry sky appearance, or they also give one more name, lumpy bumpy deposit. If you are a fan of these fancy terms, write them. But what matters for me is a granular deposit along the capillary wall for C3, very, very important, right? And like Hema said, you will have a subepithelial hump-like formation. It's same like your membranous, but the only difference here is it's subepithelial hump-like deposit. It's not just a random deposit. It has to be a hump-like deposit like this. Sudden bump will be there. Hump-like deposit is classical for PSGN, which is diagnostic of PSGN, right? Treatment overall, it is supportive management because bacterial infection. Will my body be able to take care of it? Yes. he'll be able to take care of it. Till that time, I support them. It'll come back to normal automatically, right? And obviously, we know a complication. This also can become RPGN without fail, right? We'll end with that. Hi, DC. Hello. Perfect. So that's about PSGN. PSGN can come in a long answer. Etiology, you know. Pathogenesis, you know. Pull all the clinical features of nephritic syndrome. They are most common in children here. Remember that. Add that to the clinical features. Fine. Then we know the light microscopy. We know the immunofluorescence. We know the electron microscopy as well. A word about the treatment, supportive, complication, RPGN. Clear? If everything is clear, we'll go to the next guy. Next, in the next slide, we are going to discuss two diseases. One is for namesake discussion. I don't think no one will ask that in an exam. Other one might be important. That might come in a 5 mark. Clear? Perfect. The next thing, the first one I said for namesake is minimal change disease. Everyone will want minimal change disease in exam question, right? Because one of the simplest one ever is in glomerulonephritis, minimal change disease. No one really knows what happens there. It's a damage to the food process, effaced food process, and we have classical nephrotic syndrome. The most common cause of nephrotic syndrome in children, you have cytokine mediated damage, which is going to cause efface the food process, loses the negative charge, and you'll have massive selective proteinuria, a template nephrotic syndrome. Okay. Etiology here is very long list. It could be a viral URI, it could be vaccines, it could be drugs, it could be your Hodgkin's lymphoma. They are all associations. They are not actually etiology. I have minimal change disease in associated with all of these conditions. So I exactly don't know what it is. And there's a new study which says that there's an increase in the antibody production against the proteins of slit diaphragm. The nephrin podosin, right? Proteins of slit diaphragm. That's an important finding. What they produced. Maybe in future, the concepts might change. But as of now, this is what it is. Just remember that, right? It's a minimal change disease. Classical nephrotic syndrome. Why did we name it minimal change? Because the glomerular is absolutely normal. The only thing is food process will be gone. Guys, can we see food process in the light microscopy? Yes, no, maybe. We'll be able to see them? No, right? We can't see them. So light microscope will be absolutely normal. But one change made it call it minimal change diseases. You'll have lipid vacuoles in PCT. You can have a reasoning why question which says, why do I call minimal change diseases lipoid nephrosis? The answer is simple. Because minimal change disease is a nephrotic syndrome, you will have lipiduria, and the job of proximal convoluted tubule is to reabsorb everything which is being filtered. So lipid will be reabsorbed and it will be deposited on the PCT, which gives an appearance of clear vacuoles in the PCT. So we call it lipoid nephrosis. Clear? It can be a reasoning why question easily. Now tell me, is this specific for minimal change or any nephrotic syndrome? Mostly negative for immunofluorescence. Few studies again show some amount of positivity. And electron microscopy, classical finding, effaced food process. As simple as that. Fine. Your lipoid nephrosis is a non-specific finding, can be seen in almost every case of nephrotic syndrome, right? Treatment is steroids. They have an amazing cure rate with steroids. Give steroids, waits for some time, automatically will come back to normal, right? That's about minimal change disease. I would say a dummy disease, a feel-good disease, which is there in the book, amazing prognosis, easy treatment, and nothing in the microscopy. That is your minimal change disease, right? Perfect. Next guy can come in a 5 mark. IgA nephropathy or Berger's disease. They can ask us, write a short note on Berger's disease. So do remember them. Whenever I talk about Berger, I also pull one more disease wantedly. Can anyone tell me what is this disease? Buerger, Berger's disease. What is that? Can anyone comment on that? Because if you write by mistake Berger's, you're going to lose the entire mark. Berger is IgA nephropathy. Buerger is thromboangiitis obliterans, a type of vasculitis that is different. This is different. Please don't get confused. Okay. You will be there in your toe problem. Fine. and Berger's is your IgA nephropathy. Fine. Okay. Why this is important? From a practical point of view, this is one of the most common primary glomerulonephritis worldwide. It's an IgA mediated problem. So I do have an etiology. There is a pathogenesis. Clinical features we obviously will know. We'll discuss about that. Fine. So here, a little bit background. IgA's other name is secretory immunoglobulin or mucosal immunoglobulin, right? When I have an infection in the throat, the entire mucosa will be lined by IgA in order to destroy the organisms. Organism might be only here, but I'll have entire mucosa lined by IgA. It will be secreted a lot. So there will be excess of IgA in every infection, and that will be removed beautifully by my liver. Liver does the work of detoxification and removing everything. The liver removes excess IgA. So what will happen in IgA nephropathies? I have two again, primary and secondary. Secondary is the easiest one. Liver is not functioning. In you and me also, I'll have excess IgA, they'll get deposited and cause IgA nephropathy. Simple. Even a normal IgA cannot be cleared if I have a liver issue. So I'm going to have a secondary IgA nephropathy. So what is primary IgA nephropathy? Imagine if IgA is genetically abnormal. My liver knows, okay, this IgA, my liver knows it, eats it, destroys it. So now this IgA is having genetical abnormality, looking different. My liver will not identify that. Will think someone else and leave it. That is primary IgA, right? So what you have is an abnormal glycosylated IgA or one of its subtype IgA1. This word is important. An abnormal glycosylated IgA1 so that liver cannot clear it effectively. Or I have a severe liver disease. What's the bottom line here? You have more IgA or less IgA? You have more IgA. So this IgA is going to remain in the circulation for a very long time than normal person. So what it does? What will kidney do? Kidney won't keep quiet. Kidney will filter everything, right? So kidney filters them and deposits them in the mesangium. Because of the charge and the molecular affinity, IgA deposits in the mesangium. A viva question. Can anyone tell me what is mesangium? I'm sure you know that, but do let me know again. What is mesangium? Mesangium? Mesangium is the space between the glomerular capillary loops, right? So because of the affinity, IgA accumulates and deposits in the mesangium. That is very, very important. That's how the streptococcal antigen went to the subcapsular space, right? Subepithelial space. Like that, IgA goes to the mesangium. IgA will activate alternate complement pathway. That you must have learned in your microbiology. That's what IgA does. IgA activates the alternate complement pathway. When you activate alternate complement pathway, I have the same C3, C5. But where does it happen? Capillary or mesangium? Everything happens in mesangium, right? Perfect. So when I'm having excess C5a in mesangium, is C5a chemo attractant? Yes. Who will they attract? WBCs. Where? To the mesangium. So here everything changes to the mesangium, that's all. It's same like PSGN, but the location is different. So now from the capillary, it goes outside and deposits in mesangium. Will it damage the GBM? It will. If it damages GBM, nephritic or nephrotic? We know the base. It is 100% nephritic range proteinuria, nephritic syndrome. The moment GBM is damaged, it will result in nephritic range proteinuria and nephritic syndrome. Very simple, right? That's a simple pathogenesis. Write in a flow chart. For space constraint, I have written horizontally. I want you to write vertically in an exam, so it's easy and legible. Fine, that's all. That's IgA nephropathy. So now clinical history. Only one addition I want, in addition to writing all the fits of nephritic syndrome. Now tell me, in the last year, how many mucosal infection you must have had? Mucosal infection includes gastritis, gastroenteritis, stomach pain, stomach upset, URI, UTI, everything, diarrhea. More than one? Easily, right? So IgA nephropathy is by default recurrent because almost every infection will have the same problem because the problem is not in the infection, the problem is in the mucosal immunoglobulin. So recurrence is very, very classical. Any history which says recurrent microscopic or macroscopic, doesn't matter. Hematuria is enough for me. Recurrent microscopic hematuria, the first thought is IgA nephropathy because this happens recurrently. And the most important thing, we read in PSGN itself, it does not have a lag time. It gets deposited, initiates everything, and you'll have hematuria even the second day, that's enough. And I also have a systemic variation. Like your Goodpasture syndrome, you have something called Hinot's colon purpura. Hinot's colon purpura is a vasculitis, IgA mediated vasculitis, where you will have IgA nephropathy plus vasculitis in the GIT will cause abdomen pain. Skin will cause purpura and palpable purpuras. That is a systemic disease like Goodpasture syndrome that's also possible in IgA nephropathy, right? I am reiterating this. Lag time is very, very important to know it's PSGN or IgA nephropathy. Remember that, right? Now, we know the pathogenesis, we know the clinical features. Let's move to light microscopy. Where is the problem? Mesangium. So what will happen? I'll have mesangium will widen. Not difficult to remember. And I'll have more cells. That's all. Mesangial widening, mesangial hypercellularity. As simple as that. So now immunofluorescence, right? I'll push them that side. Immunofluorescence, what antibody will have deposition? I'm sure you must have seen that, but still tell. Still comment. It's a feel-good thing when you comment the right answer. In immunofluorescence, what will you have? You'll have perfect IgA deposit. Will I have C3? Yes or no? That alone answer me. I'll have IgA deposit and I'll have in the mesangium. Will I have C3 deposit in addition to that? You obviously will have. Why? That's in the pathogenesis, na? IgA activated complement cascade, activated C3. So what I'm going to have, I'll have mesangial deposit of IgA and C3. Can I say in this patient also serum C3 will be reduced? Yes, no, maybe? Absolutely yes. That is why the difference between PSG and IgA nephropathy is the history, not the blood investigation, because here also C3 will be reduced because C3 is consumed in the pathogenesis, right? It's consumed in the pathogenesis. So here, electron microscopy, again, everything will be strictly to the mesangium. Everything, light microscopy, immunofluorescence, electron microscopy, strictly to the mesangium, fine. Now here also, treatment is predominantly supportive, but I do have one big concern here, complication. You can write the same RPGN, but one of the biggest concern is recurrence. If there's recurrent problem of glomerulus, can I say it can go to chronicity? If you say yes, can anyone tell me what is the end stage glomerulonephritis called as? You can see the heading also below, and also FSGS. This might result in chronic kidney disease and renal failure. It's a recurrent damage. Again and again and again you'll have damage which will end up in renal failure without fail. Okay, that's a problem with your IgA nephropathy. Because of the recurrence, I might lose the kidney itself at one point of time, right? Perfect. I'm zooming out. We know IgA nephropathy etiology, excess IgA, abnormal or normal IgA, liver not removing. IgA goes to the mesangium, alternate complement pathway is activated, your C5 protein comes, your chemoattractant happens, WBC comes to the mesangium, destroys the GBM and causes nephrotic syndrome. Recurrence is very, very classical here. Hinot's colon purpura, don't forget, and every change happens in the mesangium. Be it the light microscopy, be it the immunofluorescence, be it the electron microscopy part. Fine, perfect. I am zooming out here. Now, before going to the next one, okay, Syed, whenever you feel comfortable, fine, perfect. So next, before going to the next slide, I'm going to ask you a question and I want you guys to answer. RPGN, okay, can anyone tell me what will be the clinical history of RPGN? Whatever comes to your mind. Few words also is enough for me, a good sentence also is enough for me. Tell me, whatever you remember, what will be the classical clinical history of RPGN? RPGN has a very, very classical clinical history, which is you will have a rapid onset of renal failure, right? So let's say today the person who's admitted in the hospital has a creatinine of 2 milligram percentage. Suddenly within 24 to 48 hours, that's 1 to 2 days, the 2 milligram percentage becomes 8 milligram or 9 milligram percentage. That is importance. Neat nexus, all the glomerulonephritis will cause RPGN. That's absolutely right. When the creatinine goes bad within a day or completely no urine output, the sudden part is more important. Within a couple of days, it has to become worse. Only then is RPGN. Patient who's having a renal failure today, after 2 months, creatinine going 7 milligram is not RPGN. It is a slow progression, right? RPGN should be sudden, be it clinical feature like no urine output or extremely oliguric or blood level, blood urea nitrogen and creatinine spiking within a day or two. That's very, very classical. That is RPGN. It's a rapid decline in the renal function. Okay, it's not it's days, 1 or 2 days, not week. Okay, that's an error. It's not weeks, it should be within a couple of days max. That's an RPGN, right? The microscopic name of RPGN is crescentic glomerulonephritis. Now let's look at the pathogenesis. What is glomerulus? Can anyone tell me? Because if you understand what is glomerulus, pathogenesis of RPGN is simple. The only problem is we don't understand. We are in a hurry to memorize everything. Glomerulus is a tough capillary. What is the worst thing which can happen to a capillary? It can rupture. That is RPGN. That's all. Very simple. The worst thing to a capillary is glomeruli will rupture or the capillary will rupture. The moment a blood vessel ruptures, my body will automatically produce a clot formation, a fibrin clot formation. That happens here also, right? So you'll have a leakage of fibrin and obviously WBCs go outside. Where? To the Bowman space. That's a space between the capillary and the capsule, right? To the Bowman space. So this fibrin will go and irritate this area, will irritate this area. So what will happen? The cells which is lining the capsule, Bowman's capsule, will start proliferating. Those are your parietal epithelium, right? So it will cause hyperplasia of the parietal epithelium, and that hyperplastic parietal epithelium is going to create a crescent-shaped compression which will not let my glomerulus function. This is what RPGN is. Okay, it's just a rupture of the glomerular capillaries, production of the fibrin clot and the WBCs along with the proliferating parietal epithelium cause a crescent which compresses and destroys the capillary. Now this is the pathogenesis. Light microscopy, what will I see? The same crescent. What I'm going to see in light microscopy is the crescent, that's all. Crescent will be there in the Bowman space, which is composed of parietal epithelium, WBC and fibrin. Immunofluorescence is the base of classification. There are two types of positivity in IF, right? What are the positivity? Linear, granular. That's how we divide them, as simple as that. We divide RPGN into 3 patterns. Either a linear pattern or a granular pattern or negative. We call it posi-immune, right? Linear pattern, we know only one disease. Rest everything is granular. Lupus, PSGN, IgA, MPGN, everything else is granular. Every other glomerulonephritis goes to the second category, type 2 only. Third is posi-immune. Glomerulus is a capillary. We read in first class of general pathology, systemic pathology, FARRE, right? Glomerulonephritis, vasculitis. Glomerulus is a capillary, which is nothing but a small vessel. So can I say small vessel vasculitis can damage the glomerular capillary? Yes, they can. Vaginous microscopic polyangiitis. This is nothing but small vessel vasculitis. But they don't cause immunofluorescence in the kidney. They'll have immunofluorescence elsewhere, right? So they will also cause RPGN, but they'll be negative for IF. We call them posi-immune IF. So we know the light microscopy. The base of classification is based on immunofluorescence. Obviously, we have to look at the electron microscopy. Electron microscopy is simple. The starting point, break in the basement membrane. You will see exactly that the basement membrane has ruptured or broken, because that's where it started, right? Capillary rupture. That's classical electron microscopy. Can anyone tell me what could be the treatment? Don't say supportive here, right? Supportive will work for diseases which don't kill us, right? Like fever. Okay, supportive management is fine. But disease which kill us, I cannot be supportive, right? So it's a acute onset of renal failure. For any acute onset of renal failure, you have to do an immediate hemodialysis. Make sure the creatinine will drop from 7, 8 to 1 or 2 as soon as possible. Do a hemodialysis, then the kidney will automatically heal. Wait for the time the kidney can take care and then leave the patient. Transplant is not possible immediately, right, Dharmishta? I need to have a donor, I need to do a matching, right? So to manage the thing, I have to do an immediate hemodialysis. That's must, because an extreme levels of creatinine will cause uremic pericarditis, will cause uremic encephalitis, where we might lose the patient. Okay, that's the reason we need to do an immediate hemodialysis. That's a treatment modality for RPGN, right? I'm zooming out a little bit. We know what is RPGN, the definition, the etiology, everything is the etiology. We know the pathogenic part, light microscopy, IF is the base of classification, your electron microscopy, and also the treatment. Done? Let's go to FSGS. There's only one difference here. RPGN is acute exacerbation, extreme high fever. FSGS is chronicity. And what's the hallmark of chronicity? TDHF, that's all. Tissue destruction, healing by fibrosis. FSGS is a chronic progressive scarring or sclerosis of the glomeruli. It's the most common cause of nephrotic syndrome in adults throughout the world. Because every disease at some point of time will become FSGS. The only thing here is recurrence. More and more injury keeps on happening to the podocyte or the foot process. Obviously, there will be scarring, right? So let's say this is a glomerulus. You need not be artistic in an exam. Draw a glomerulus like this. That's enough. The teacher will understand without fail. If you're artistic, that's a bonus point. That's all. First damage happens here. Heals by sclerosis, sclerosed glomeruli. Second damage happens here. Heals by sclerosis. Third damage happens here. Heals by sclerosis. That's what we call it. Segmental scarring. It will not scar the entire glomerulus at the same time. It might, but it might not also. So we'll have segmental scarring and not the entire, all the glomeruli in the kidney at the same time. Focal. That's why we have focal scarring. Only few of the glomeruli are affected, and segmental scarring. Only a portion of the glomeruli is affected. Right? That's the name FSGS. It's focal segmental glomerular sclerosis. So what diseases do cause them? Every glomerulonephritis, whatever we read till now, will cause them. Yes, except one. Who? Who will not cause chronic disease? Who will not cause chronic disease? Your MCD will not cause chronicity, right? Except MCD, everything will cause, right? That is your secondary. It can be due to any secondary to any medical renal disease. Medical renal diseases, your glomerulonephritis. It can be secondary to that without fail, except for menial chain disease. I do have primary or congenital cause. If you remember in your first year, you must have read about slit diaphragm proteins, the filtration barrier. I do have proteins called as nephrin podosin. I can have destruction of nephrin. Nephrin is not there. Podocytes will not function. These are podocytes, right? Like finger-like projections. They have to move like this. The connection is nephrin. If the nephrin is lost, they don't function. They don't function, they'll be destroyed. Type 1 is mutation in nephrin, the most common type, also called as Finnish type of nephrotic syndrome. Type 2 is mutation in podosin, which is also one of the type. Have multiple types. Bare minimum, remember 2. Nephrin, podosin mutation. HIV can cause. COVID can cause. Obesity can cause. All this is secondary problem. How will obesity cause? Obesity is a systemic hyperinflammatory state, right? Every inflammation will destroy everything, including glomeruli. That's all. And we have one more thing question. Renal ablation FSGS. You remove one kidney in a patient. The other kidney is always overworked. It will reach a point of burnt out stage. That is renal ablation FSGS, right? That will also happen. We know the etiology. We know the pathogenesis. So FSGS is a, can I say, kind of a terminal stage? Yes. So which means I need ways to classify them. Microscopically, what I'll see is, I'll see sclerotic glomeruli, which can be patchy, focal and segmental. Sclerosis is a pink color destruction. I do have a classification called as Columbia classification. Okay. Columbia classification, the classification of FSGS. We have 5 different classes of FSGS. At least remember one of them. That is a collapsing variant of FSGS. That is one of the worst outcome. Associated with a deadly infection like HIV, it's collapsing. The entire glomerulus collapses. It's getting sclerosed and collapsing, not functioning at all, right? Characterized by entire glomerular tuft collapse and mesangiolysis. It'll lyse and it'll collapse. Collapsing variant can come in a one-liner or a viva. That's seen especially with HIV and has a very poor prognosis. Fine. Okay. So electron microscopy is not specific. Light microscopy is based on the etiology and immunophilia is based on the etiology, and we know the light microscopy without fail. Fine. Okay. You'll have sclerosis. You'll have additions to the Bowman's capsule. Fine. Okay. Treatment. It is CKD. How do you treat CKD? It's going to be based on the class of CKD we treat them. I'll add only one word. Remember this forever. CKD 4 or 5 will require a renal replacement therapy. Never ever forget this. When I say renal replacement therapy, dialysis or a transplant, because class 4, class 5 CKD is literally a waste kidney. It's not working, so we have to do a dialysis or a renal transplant for that patient. Fine. Is that clear? That's your FSGS and your RPGN. Fine. So we know quite a few clear-cut glomerulonephritis which you have to read. Fine. Okay. Now let's go to the next topic. I'm going to ask you questions as usual. If you're ready, answer them. Okay. Can anyone tell me, if I have a patient, 45-year-old patient presenting with hypertension, and on examination there's a huge mass in the abdomen, on an ultrasonogram there are multiple cysts, what could be your diagnosis? Anyone? What could be a diagnosis? It is a classical history of your ADPKD or ARPKD. Which one? It is ADPKD. 45-year-old, right? It cannot be ARPKD, because ADPKD is the one which presents later in life. ARPKD is the one which presents early in life, right? Perfect. That's your ADPKD. So we are going to talk about cystic kidney diseases. Of the cystic kidney diseases, ADPKD, ARPKD are must to know. Rest of them, if it comes in an essay question, you should be able to write them, right? Perfect. Done. Now, for cystic kidney disease, the pathogenesis has changed over the period of years. We have now used the term, this is the term which I want you to remember. Every cystic kidney disease is an abnormal ciliary function. It's not the cyst which is the problem. It's the cilia, it's the problem. Ciliary dysfunction is the problem which is there in cystic kidney disease. What happens is, normal cilia, the PCT cilia is there, which helps to maintain polarity of the tubular architecture. Cilia is not just to increase the surface area. Cilia will tell me, okay, this surface is luminal surface. Because urine flows here, it will tell me this is a luminal surface. Helps to maintain the polarity. The moment ciliary dysfunction happens, there will be loss of polarity. And the architecture of the tubules will not be proper. It will be very weird. Starts collecting little bit of your fluid. And that will result in the cyst. It's a ciliary dysfunction. This pathogenesis, what is seen here, can be written for every cystic kidney disease, irrespective of the type. If they ask a short note on ADPKD, write the etiology, gene mutation, pathogenesis, write the same. ARPKD, etiology, gene mutation, pathogenesis, write the same. Fine. It's altered ciliary function and abnormal ciliary function, right? If there's an abnormal ciliary function, my polarity of the tubular epithelial cells will be altered, which will dysfunction the cilia. I'll have an abnormal ciliary signaling, which also causes an altered calcium flux. Calcium is very, very important to maintain the homeostasis. This abnormal ciliary signaling will alter the growth of the tubule, not just that, which also alter the growth of the extracellular matrix. Of extracellular matrix and the growth of the tubule will be altered. Once the growth of the tubule and the matrix is altered, which will start accumulating fluid. Altered calcium flux now, it will cause increase in the accumulation of edema fluid. And all this together will end up in forming a cyst, right? Alteration in the tubules growth, alteration in the stroma's growth, that is extracellular matrix, and also alteration in your accumulation of fluid. Fine. Santosh, start with this, right? Instead of thinking what to do next, first start and let's see from where we can take it from there. Fine. Okay. That's the common pathogens of every cystic kidney disease. Now we are going to talk in detail about ADPKD, ARPKD, and few other cystic kidney disease. First, ADPKD. Every autosomal disease presents later in life. Don't forget that. Whatever it be the autosomal dominant disease will present later in life only, 30, 40 years, third or fourth decade. And the way they present is hypertension with a mass. There are two gene mutations here. We have polycystin 1 and polycystin 2. If you can remember the chromosomes, great. If not, at least remember polycystin 1 and 2. Okay. Because of the polycystin 1 and 2 mutation, I have an altered polarity due to abnormal ciliary function. You have a cyst. Gross examination, you'll have huge palpable masses. The way to diagnose ADPKD or ARPKD is the gross, not the microscopy. Because in microscopy, every cyst will look the same. So it's more of a clinical diagnosis and an ultrasound diagnosis, not a microscopic diagnosis, right? So here you will see cyst on the outer surface plus on the cut surface. It's not seen only on the cut surface. Without even cutting the kidney, you can see the cyst. And also in the cut surface, you can see the cyst. Plus, you will have cyst in cortex and medulla. You'll have cyst in outer surface, cut surface, cyst in cortex and medulla, classical for ADPKD. See, there are cyst, accumulation of fluid. So what do you think can be complication of them? Any random complication, what do you know? Just think. I have cyst which is accumulating fluid. Is there a possibility fluid can store a little bit of minerals, salts and cause renal calculi? Yes. Infarction? Possible, right? Complication, I can have infarctions because of the cyst. I can have stone formation because of the cyst. Because it's accumulating, right? It can happen, right? This will not cause cancer. These are the complications what can happen, and obviously I can have renal failure. That also is possible without fail, right? And I do have one important association for ADPKD. Can anyone tell me the association? Emilia Clarke has the association. The Game of Thrones mother of dragon or whatever she acted for. She had berry aneurysm. Berry aneurysm is one of the important complications of important association of ADPKD, right? Along with the cyst in the kidney, you'll have cyst in the liver, you'll have cyst in the pancreas and multiple organs, and also aneurysm in the brain. That's a classical association here, right? Perfect. I'm zooming out a little bit. Age of onset is late, third or fourth decade. We have two mutations. We have a common pathogenesis. Clinical history around fourth or fifth decade, you'll have hypertension. On examination, there'll be a palpable mass. Post-surgery, I can diagnose based on gross, outer surface, cut surface cyst, cortex, medulla cyst. I can have few complications and one of the association. Fine. Let's go to ARPKD. So ARPKD is autosomal recessive. If you want to write one more point, inheritance, autosomal recessive, right? It is fine. Mutation is in the gene called, protein called as fibrocystin, which is in chromosome 6. Same pathogenesis. Alteration in the ciliary dysfunction. That's all. Same pathogenesis. Fine. So ARPKD has multiple subtypes. It can be present in infancy or childhood. Sometimes even it can be present before birth. Right? I have perinatal presentation. I have neonatal. I have infantile. And I have juvenile. All these are the types of ARPKD. Infantile ARPKD, perinatal ARPKD, right? More early it is, more serious it is. Because juvenile renal failure, I can try to handle. But perinatal renal failure, very difficult to handle, right? So more early, more difficult is the prognosis, fine? How do they present? They present classically with renal failure. Infant or a juvenile with renal failure, one of the causes this. How do I diagnose? The most important thing is the outer surface will be smooth. This is a real patient's outer surface. Look at the kidney surface. Outer surface is smooth. There's no cyst in the outer surface. Cyst will be there in cortex as well as medulla. But a very important clue can come in a viva. The cortical cysts are parallel to the, perpendicular to the surface, and they are parallel to each other, right? This is a little bit blurred picture, but if this is the cortex, cyst will be like this. They'll be elongated and they'll be parallel to each other and they'll be perpendicular to the cortical surface. This is a very, very unique diagnostic clue for ARPKD. Fine. Association. One of the worst association is hepatic fibrosis. Imagine the kid having a renal failure and a liver failure at the same time. Can't handle, right? And the prognosis of ARPKD is definitely much worse than ADPKD because of the age. That's all, right? That's about ARPKD. Okay. So we have two cysts in the medulla. One we call it nephronophthisis. I'm not going to the types at all. There are like 11, 12 types. Nephronophthisis are diseases with corticomedullary junction cyst. Okay. They have cyst in the medulla, especially in the corticomedullary junction. They can progress to renal failure. Just remember them, that's enough. There are multiple subtypes and they might destroy the kidney and go to renal failure, right? Next is medullary sponge kidney. It's more of a spotter. If there's an image-based question, you might have it. You'll have kidney cyst. There'll be very, very tiny cyst in the medulla, same corticomedullary junction, like the porosities of a sponge. Like a sponge, we'll have very, very tiny cysts. They are mostly incidental diagnosis. You take an ultrasonogram for something else, you will find this, that's all. They don't cause renal failure, they don't affect the kidney, nothing will happen, right? Incidental diagnosis for medullary sponge kidney, okay? Perfect. Next guy is multicystic renal dysplasia. This can come as a one-liner, especially when you go to NEET, PG, INACT or FMG, whatever exam you're writing. It's a very classical MCQ point. If you see any patient, any history which says non-functioning kidney at infancy, it's not renal failure. Please remember, non-functioning kidney. The kidney does not function, zero function. That's different from renal failure. Renal failure in infancy, I'll think of ARPKD. Non-functioning kidney, I'll think of a multicystic renal dysplasia. What happens here is the entire kidney is replaced by cyst. It will not even look like a kidney. Completely replaced. No functioning glomerulus. That's why we call it non-functioning kidney. What I see in microscopy? Fetal immature glomeruli, obviously will have cyst. In addition to that, cartilage. That's the reason dysplasia. I don't expect cartilage in the kidney, right? But here you'll have cartilage in the kidney, right? That's the reason dysplasia. Ignore this. Fine. Fetal glomeruli, cartilage, cystic replacement of the kidney, multicystic renal dysplasia. The only way is do a transplant. Bilateral, have to do a transplant at the earliest. Okay. Next, again to fill things up, simple renal tests. The most common one, when you go to your final year, you'll start getting reports. How many of your relatives are sending reports to you? They must have sent, right? They'll definitely keep sending it, right? So when they keep sending reports, one of the common thing is there's a cyst in the kidney. Random finding, it'll do nothing. Most common cyst, cortical cyst, usually unilateral, most of the time incidental diagnosis. Same problem, it can rupture or it can have an infection. Don't worry about it. It will not cause cancer at any cost. It's a cyst, randomly happens. That's it. Wear and tear. Everything has a wear and tear. Kidney also will have wear and tear, right? Last but not the least, one of the important guys, acquired renal cyst. This every doctor should know because you put any patient on chronic hemodialysis, you will have this. Multiple cysts might be there in multiple places of the kidney. The most important thing is whenever you start seeing a solid area in the cyst, please be careful because the only cystic kidney disease where you can have a risk of malignancy. We have seen 6 of them, right? Which one, DC? Which disease? Multicystic renal dysplasia. It's a sporadic disease. We are not able to identify the inheritance of that. Fine. Okay. This is the only cystic kidney disease which can cause the risk of cancer. ADPKD does not. ARPKD does not. Your nephronophthisis does not. Your medullary sponge does not. Simple cyst does not. Only cyst which can cause increased risk of cancer is acquired cystic kidney disease. Do remember that, right? I'm zooming out. It's just one page which will give us the explanation for almost every cystic kidney disease. And we have a common pathogenesis, ciliary dysfunction. All the proteins mutated which is known to us are part of the tubular cilia. When they are abnormal, everything happens here. Fine. Clear? Any doubt? Do let me know. IK Vasu, tell me if you have any doubt. If not, let's go to few of the classical images which can come in a practical exam or in a Viva question. There are few extremely important structures which you have to know with respect to renal pathology. I'll tell you the names. You tell me where you see them. KW lesions. Where you see KW lesions? Everyone. These are simple ones. You should not forget it. KW lesion, where do you see them? You know the answer. Diabetic kidney, right? Perfect. Flea-bitten kidney, where do you see them? Come on, these are simple ones. You have to answer them. Flea-bitten kidney is classically seen in a condition called as malignant hypertension, right? Perfect. Hyaline arteriolosclerosis. Hyaline arteriolosclerosis, where do you see them? It is seen in, okay, conditions of benign hypertension. Kidney is a bit difficult, is it? Okay, let's see all three of them. Hypertension-induced changes and diabetes-induced changes in renal parenchyma might not come as a short note, but definitely possible to come in a viva, or if your university has 2-3 mark questions, you might have them, right? Benign hypertension is normal hypertension, long-standing chronic hypertension. Whenever the blood pressure increases, it's an outward force, right? It will push everything outside. That's what, as per the Frank-Starling interaction, it's an outward force. So what happens? The more pressure, more plasma proteins will go to the wall. The plasma proteins get deposited. Proteins are pink in color. Over the period of time, the entire wall becomes pink in color. Anything pink in color, if it is not made of a single structure, I use the term hyaline. We call them hyaline arteriolosclerosis. Because arterioles are the resistance vessels. That's where the first change comes. Because of this arteriolosclerosis, the wall becomes thicker, lumen becomes smaller. When the lumen becomes smaller, can there be ischemia? Yes. Can it cause tiny renal infarcts? Yes. So what happens? Kidney becomes smaller. The surface will not become uniform. It will become irregular or granular, right? It will become granular. Granular contracted kidney is one of the classical gross findings of your chronic hypertension. It's also seen in patients with chronic glomerulonephritis. Clear? Okay, very classical finding. These two terms are very important. Hyaline arteriolosclerosis and granular contracted kidney are classical things seen in benign hypertension. Done? Okay. Now the next one, which is malignant hypertension. Malignant hypertension, it is very high grade, like 120 or 200 millimeter mercury, hypertensive emergencies and urgencies. In 120 millimeter of mercury, do you think the arterioles can survive? What will happen? They will rupture. Fibrinoid necrosis. That's the first microscopic finding. I cannot let my arterioles rupture. We always have an adaptive response. If something ruptures, I will make it harder so it does not rupture. So what I do is, I create new layers of smooth muscle and make them harder. When I create new layers of smooth muscle, it looks hyperplastic. It's nothing but smooth muscle proliferation. We call it hyperplastic arteriolosclerosis, or the term onion skinning. I am sure you remember onion skinning appearance, right? Onion skinning in blood vessels is hyperplastic arteriolosclerosis. I want you to remember hyperplastic, not onion. I'll tell you the reason. Hyperplasia, hypertrophy, metaplasia, atrophy. Are they reversible or irreversible? What do you guys think? These are all reversible or irreversible? You know all these four, right? They are reversible, which means if this patient's tied through the crisis, they are reversible. Fine. No, Hema. Flea-bitten kidney, the term is restricted for your malignant hypertension only. Okay. If any other book says something else, don't trust them. If you have RPGN in FSG, in case of your PSGN, right? There also will have capillary rupture. Whenever capillary ruptures, I will have petechial hemorrhages. Flea-bitten kidney is nothing but petechial hemorrhages. Okay, it's flea-bitten kidney. It's nothing but small petechial hemorrhages on renal surface. Any condition where the vessel ruptures, I can have it. Maybe I can have it in RPGN, but not in case of PSGN, right? You don't see them. It's due to rupture of arterioles, classical for your malignant hypertension. It can also be seen in snake bite. There are a few snakes which are hemotoxic snakes. You'll read them in forensic medicine. There also you can see. Some poisoning you can see, but not in PSGN. Fine. Perfect. These are two things with respect to hypertension, benign and malignant. Let's come to diabetic nephropathy. See, in diabetic nephropathy, diabetes is a big problem, right? So what happens is, sugar alone is not the concern for me. Sugar over a period of years keeps on accumulating and they form a product called as advanced glycosylated end products, age products. These age products are the problem. They deposit in blood vessel and cause a problem, and they activate a receptor called as RAGE receptor and they cause a problem. We'll see them when you go to diabetes in detail. So these age products, when they deposit in the blood vessel, initially what will happen is they will thicken the capillary wall. That's a first change. Thickening of the glomerular capillary wall. It will alter the GFR and also cause little bit permeable tissue which causes microalbuminuria. You must have read in your biochemistry also, one of the earliest features is microalbuminuria in case of diabetic nephropathy. Alteration of GFR is also very, very important. Then microalbuminuria also, right? So now I'm having a capillary where the age products deposit like this. There's a capillary and the age products start depositing here. But over the period of years, what will happen is it will keep on depositing more and more and more and more and more and more and becomes a nodule. That's your KW nodule or your KW lesion. If you leave it for some more time, this nodule will still more and more and more and more and deposit and compress the entire glomeruli. No blood supply. Sclerosis, that's all, right? The first change is thickening of the capillary wall. Then it becomes partially reversible when you have a nodule. This nodule is your KW lesion. You have a Clemensstein-Wilson lesion. These are PAS positive nodules. A very specific finding for diabetic nephropathy, do remember them. You'll have a nodule in the glomerular capillary. But over the period of time, advanced lesion always will become irreversible, that is FSGS. Tubule will be gone, interstitium will have fibrosis. That's an irreversible stage and this is the end stage. Okay. It's diabetes. There's no autoantibody involved here. So diabetic kidney will be negative for immunofluorescence. DAF is direct immunofluorescence. Done? Okay. That's about the common diseases in real life, but not very much common for a long answer question in an exam. Fine. Okay. Done? Fine. Now let's go to the next question. The next question, I'll give you history. You will tell me the diagnosis. If you tell the diagnosis correctly, we'll go and talk about them, right? Ready? Some of you might have also experienced that. Let's say any age group, 25-year-old person, male, healthy, active lifestyle, and suddenly presents to the casualty department with an extremely severe pain in the right renal area or just below the ribs. On pressing that area below the 12th rib or some around the area in the loin, there's an extreme amount of pain and tenderness. What is the diagnosis? It's a classical history. What do you think is the diagnosis? That's very, very classical for renal calculi, right? Renal stones or renal calculi. That's a classical example. Sudden onset of pain in the renal angle along with tenderness is renal calculi. Renal stones can come for your short answer. Possible because there are multiple types. A very concrete pathogenesis easily can come in a short answer. Long answer very unlikely, but short answer can definitely come. Right? So nothing but the crystalline concretions because of supersaturation of urine and stone forming substances. Fine. We read a study about gallbladder stones. The pathogenesis is almost same. Mariam, RCC will not have pain. Painless is all, for every cancer, painless is always the clue. Do remember that. Fine. It's always supersaturation. It's a liquid. This liquid can hold only a certain amount of mineral. If the mineral becomes more or the liquid becomes dehydrated, automatically it will crystallize. That's what is called as supersaturation. Fine. Okay. So what happens is urine becomes supersaturated with any of the substances. Can be more calcium, right? Or can be more phosphate, can be more uric acid, anything, right? So nucleation happens. You must have the same heading in gallbladder calculi also, right? Nucleation is the first starting point of a crystal, right? Now, initially it was like this. Calcium as an ion, calcium crystallizes. That's a central nidus called as nucleation. On top of the nucleation, more and more and more calcium deposits, additional more mineral deposits, and forms a stone formation. That's crystal growth. Because only calcium cannot form it because it will break easily, right? I need a little bit of matrix material, oxalate, right? Phosphate, right? Something should be there, right? Then the crystal grows, and then multiple crystals can adhere each other, can become a large stone, especially positive in your Stewart calculi. I can have a huge stone called as a staghorn calculi. Can happen, right? Not in everything, but it definitely can happen, right? Then the crystal will be trapped within the renal tubules or papillae. Instead of being washed away, this causes the pain. Okay. Especially, someone said ureteric. The pain in renal calculi is not due to the calculi, it's because of the muscle. Let's say I have a calculi which got dislodged, which went into the ureter. Okay, there's a ureter, and we have a calculi here. Will ureter have peristalsis? It'll have. So the moment ureter has peristalsis, when it moves, when it contracts and moves, it's contracting on a stone. That is the pain. We call it a spasmodic pain. It's a spasm which is causing this pain. We treat it with buscopan, antispasmodic. Fine. Okay. This is the pathogens of a renal calculi. So what are the factors which can predispose to calculi formation? I have two things here. Either I have more amount of these supersaturation factors. We call them promoters. Hypercalciuria, hyperoxaluria, hyperuricemia, cystinuria, or UTI. Infection can predispose. When the concentration of the particular mineral is more, definitely promoting. Reduced citrate is a inhibitor. There are few inhibitors for stone formation for me, right? Citrate, magnesium, they are reduced. Again, I have more stone formation risk. Nephrocalcin, this is a crystallizing inhibitor. My body is endowed with that. If that reduces also, I have a problem. Both acting in balance, resulting in the entire crystal formation, forms the calculi. Severe classical renal colic, renal angle tenderness, this will be there. It will irritate, cause tiny bleeding, you will have hematuria, and if it migrates to deep places, it can even block. And we can also have urinary obstruction, and rarely we also can have hydronephrosis. The entire kidney can become swollen, filled with urine fluid. We call it hydronephrosis, right? So these are the clinical features of uric acid calculi. Can anyone tell me the types of calculi you know? I'll tell you types of calculi. You tell me the shape of the crystal in urine. Calcium stones, calcium oxalate or calcium phosphate. That's the most common one. Calcium oxalate crystals, most common. Can anyone tell me the shape of the calcium oxalate crystals in microscopy? In urine microscopy. How does it look like? Calcium oxalate will have a classical envelope shaped crystal, right? It will have a envelope shaped crystal. It's a most common renal stone. It will look like an envelope in a urine microscopy. Can I diagnose with them? Yes. Does it have any diagnostic significance? Actually, no. All these crystals, I'm going to treat the same way. But yes, can come in a image-based question in NEET PG, or they can ask in a Viva, right? Next is your Stewart stone, triple phosphate stone, right? Magnesium ammonium phosphate. Not that common, but one of the important thing is it is very common in infections of the UTI. History of UTI and a stone, think of Stewart calculi. Stewart calculi, other name is, it's also called as an staghorn calculi. They can be very, very, very big, obstructing the entire renal pelvis. That's one of the calculi which can cause hydronephrosis, right? So it can cause coffin lid crystals. So the crystals looks like a coffin lid. It's a coffin lid crystal calculi, right? Staghorn calculi can stop the entire urine output and can cause hydronephrosis. Uric acid stones, it's classical. Hyperuricemia, and these are radiolucent stones, remember them. One important thing, I'm putting a star mark here because we always think that uric acid is needle-shaped crystals in gout. That will definitely come and cross your mind. Uric acid is rhomboid-shaped crystals in the urine and needle-shaped crystals in the synovial fluid, not in the urine. It has different appearances. Do remember them, right? Then cystine stones, seen in hereditary hypercystinuria, very rare crystals, right? But it's a very important crystal, hexagonal shape. Why it's important is, this is one of the hardest calculi. The treatment of calculi, you can see that envelope shaped crystals, coffin lid shaped crystals, rhomboid crystals, hexagonal shaped crystals, and these are sodium urate in the joints. Sodium urate is different from the uric acid stones, what you see in the urine microscopy. Fine. Treatment for renal stones: one, increased water intake, obviously to prevent it. Okay. Second, antispasmodic like Buscopan. You must have known more antispasmodic, write them. Third one of thing is extracorporeal shock wave lithotripsy, ESWL. Just write lithotripsy. Lithostones, tripsy is breaking. We break it using sound waves. That's a treatment. Okay. But one stone which cannot be broken by the sound waves is cystine stones, because they are the hardest calculi. And that's the only calculi which I'm worried that I should never miss in diagnosis. Fine. Apart from that, the shape of the crystals are primarily for theoretical purpose, right? This can come in a short note. You know the predisposing factor. We know the pathogenic model. We know the classical clinical history. We know how to identify them based on microscopy, and a little bit about treatment. Any doubt? Do let me know. If not, we'll go to the next question. Next question is important, where we are going to talk about renal tumors. Okay. Before going to renal tumors, I'll ask you a few random questions. Let's see how many of you can answer the question. Can anyone tell me what is the classical presentation for renal cell carcinoma? There's actually a triad. If you can tell all the components of the triad, amazing. If not, at least one or few of them. Classical clinical history of a patient with renal cell carcinoma. Abdomen mass, abdomen pain, hematuria. This is a painless hematuria. This is a classical triad of renal cell carcinoma. Not always you will see all of them. Sometimes you will see 1, 2, sometimes you will not see anything. Fine. Sometimes it will be an incidental diagnosis. If I tell you history of 5-year-old has a renal tumor, or 10-year-old has a renal tumor, what will be the first tumor which will come to your mind? First tumor which will come to your mind when I say 10-year-old with renal tumor. The second question, answer them. I'll keep asking questions. What's the most common variant or subtype of renal cell carcinoma? Meena, it is there in the PW app under the FARRE batch. You can have them there, or I'll share it in the WhatsApp groups. Okay. Next, can anyone name at least one mutation which is commonly seen in renal cell carcinoma? Great. Children with tumor is Wilms tumor, without a doubt. The most common variant of renal cell carcinoma is undoubtedly clear cell renal cell carcinoma. The gene mutation is at least one is von Hippel-Lindau gene mutation, right? Perfect. Now let's go to renal tumors. Renal tumors has obviously benign as well as malignant. Everything has benign as well as malignant. Benign, there are two tumors which I want you to know. I'll exactly tell only thing which I want you to remember. The first benign tumor is angiomyolipoma. It's a perivascular epithelioid cell tumor, PCOMA. It's a type of PCOMA. The only reason which I want you to know is it is seen with a condition called as tuberous sclerosis. Microscopy, angiomyolipoma. If a question comes, write a note on AML of kidney. Don't write acute myeloid leukemia, because this also is called as AML, right? Only importance for undergraduate is association with a history of tuberous sclerosis. You have to remember them. Fine. Okay. Now, like I said, history for renal cancers. Elderly patient with a triad of abdomen mass, abdomen pain, hematuria. And the hematuria by default is a painless hematuria. Most of the cancers are by default painless, right? This is a triad of renal cell carcinoma. Not always we see all of them. We can see one, we can see two. Sometimes we will not see anything. Instantly you do an ultrasonogram, a tiny mass is there, renal cell carcinoma. That's how it is, fine. Okay. History, I've been repeating this again. For any cancer, I want a sporadic history. I want a syndromic. If you know the pathogenesis, subtypes, microscopy, marker if you know. That's all. Fine. You have obesity, tobacco, petroleum products, and asbestos as the common sporadic history. Tobacco is very, very important. Don't forget it. smoke and the polycyclic hydrocarbons which comes from the smoke are one of the important risk factors for renal cell carcinoma. And petroleum products, the aniline dye, benzidine, all of them also increase the risk, right? Syndrome. We have 4 syndromes. If you can remember all 4, great, but at least don't forget one Hippel-Lindau syndrome. One clue, all of them are autosomal dominant. So one easy way to remember, whatever syndrome you write, you can add 1 point, autosomal dominant inheritance. One Hippel-Lindau syndrome, VHL gene mutation, and the cancer type what I see in the kidney is clear cell renal cell carcinoma. Clear cell type, that's a common type. That's what we see in one Hippel-Lindau syndrome. Apart from this, we can have pheochromocytoma, hemangiomas everywhere in the body, right? Second, actually this, if you remember the name, you can write a lot. Hereditary leiomyoma plus RCC syndrome, which means this patient will have multiple leiomyoma in the body, in the skin, in the blood vessel, in the uterus, and they are autosomal dominant. The enzyme mutated is called as fumarate dehydratase, FH gene, that's the mutation. Here you'll have papillary RCC plus lots of leiomyomas in the body, right? Third, it's a hereditary papillary carcinoma. It's a MET oncogene, proto-oncogene mutation, also an autosomal dominant, hereditary papillary. So microscopy will be papillary, right? For this Burt-Hawk-Dubé syndrome, the gene name is, look at the first line, letter, Burt-Hawk-Dubé, BHD gene. Gene codes for folliculin, follicles, hair follicles. So you'll have skin adnexal tumors plus renal cell carcinoma. Here I don't have any specific type. Many type of renal cell carcinoma can have it, right? Okay. Vena, it will be there in the MedEd under the batch of FARRE, which is a free batch. Okay. Next. So microscopy and gross wise, one thing is the origin. Fine. PCT is the origin for clear cell renal cell carcinoma, which by default is the most common subtype. This has a little bit of controversy. Can come from PCT, can come from DCT, because papillary renal cell carcinoma is a multifocal lesion and multifocal origin. Fine. The multifocality is the one unique thing for papillary renal cell carcinoma. Okay. Most commonly seen in upper pole, but I can see in lower pole also clear cell renal cell carcinoma. It has lots and lots of capillaries along with clear cells. That's the microscopic finding, right? The moment I have thin-walled capillaries, grossly, can I have hemorrhage? Without doubt. This word is what your examiner is going to look for if it comes in a viva to explain a clear cell carcinoma spotter. Variegated appearance, which means a solid tumor with areas of hemorrhage. Variegated. This word is very important. That's classical for clear cell RCC. It is yellow in color because it is fat rich. That is the reason in microscopy it is clear. Okay. That's the reason in microscopy it's exactly clear. That's your fat and glycogen which makes them a clear cell, right? As to with syndrome or even in sporadic forms, I can have VHL mutation only, fine? Next, your papillary RCC. It's papillae. Whenever you have papillae, you'll always have one more finding which is samoma bodies. Anything with papillae will always have samoma bodies. Do remember them. You can write it for any tumor with papillae. Multifocal lesions. I will tell you exactly why multifocal. Because the gene mutation. MET proto-oncogene is a gene mutated. This produces a factor called as scatter factor. Fine? Okay? It's a scatter factor. So what happens is, this is a growth factor. This scatters. So in 5 different places, it starts producing new cells. That's why multifocality. That's why I have a confusion between PCT or DCT. Robin says DCT, WH says PCT, different books says different thing, right? Because of the scattering, I can have multifocal lesions grossly. One may be big, one may be small, and microscopy of papillae with fibrovascular core and some more bodies. Fine. Next. We'll go to the third one. Oncocytoma is a benign tumor. I have used it for comparison here, right? We have a cell called type of RCC called chromophobe RCC. Intercalated cells of collecting duct. This also is from intercalated cells of collecting duct. It's very similar. If you look at the gross, encapsulated, okay, unencapsulated, but well defined. Brown color, central scar. Looks same in gross. If it looks same in gross, it will almost look same in your CT, MRI and ultrasonogram. The only thing is capsule. Capsule is very thin, very difficult to identify, right? Microscopy. Both will have abundant pink color cytoplasm. Abundant pink cytoplasm, oncocytes, right? Every oncocyte will have abundant pink cytoplasm. But the most important thing is this perinuclear halo. It'll have clearing surrounding it, but here it'll be purely pink color cytoplasm. It'll be purely pink color cytoplasm. You will not have a perinuclear halo. Perinuclear halo is characteristic of your chromophobe RCC, not seen in case of an oncocytoma, right? It's a benign tumor. If at all I want a marker, Hale's colloidal ion is a marker which is negative in oncocytoma. It's positive in case of an chromophobe RCC. And chromophobe RCC is the RCC with best prognosis. Okay, that's RCC with best prognosis. This gives a tiny table which is comparing most of the required tumors, few unusual tumors. Collecting that Bellini, one of the worst prognosis, extremely desmoplastic lesion. Origin, collecting duct. This is unique. We have a translocation associated RCC, XP11, because I have a TFE3 transcription factor mutation here. That's the one which is abnormal here. Microscopy allow a combination of papillae and clear cells. But the most important thing is age. 25-year-old renal cancer. It is XP11 translocation associated RCC. That's all. It's an age-based diagnosis, and obviously in microscopy, I'll have the finding, and TFE3 will be positive in IHC. Fine. Just for one liner. If there's a history of sickle cell anemia, sickle cell trait, and a renal cell carcinoma, think of a medullary RCC. That's a unique one. Fine. Okay. So we know quite a good amount of cancers. Again, I'm reiterating: sporadic, syndromic, gross microscopy, markers if required. That's all, right? Last but not least, Wilms syndrome. Okay. Wilms is also called as nephroblastoma, the most common malignant tumor in the kidney in children. Wilms can be both sporadic and syndromic. Three syndromes, all the three are important. WAGR, WT1 mutation, okay, aniridia, genitourinary abnormalities, mental retardation. The term retardation is removed, but still WAGR syndrome has the term retardation, right? WAGR, Wilms tumor, aniridia, genitourinary abnormality, mental retardation. Very classical, right? Dennis Dash. This also is WT1 mutation. There are two syndromes with WT1, one is T2. Very aggressive variant of Wilms plus gonadal dysgenesis. If there's history of hermaphroditism and Wilms tumor, I will think of Dennis Dash syndrome as an aggressive variant of Wilms, right? Third is Beckwith-Wiedemann syndrome. The word is very important here. Beckwith-Wiedemann, two W's, WT2. Beckwith-Wiedemann. Everything in this person is bigger, right? Wilms tumor, big size kidney, hemihypertrophy, half of the body will be bigger. Omphalocele, umbilical opening is bigger. That's why the contents of the gut will come outside. Hepatoblastoma, liver might be bigger. Not just tumor, hepatomegaly also will be there. The reason why everything is bigger is the WT2 gene, right? This codes for insulin-like growth factor 1. Can I say IGF-1 helps in growth? That's all. The reason why everything is bigger here is the pathogenesis. Insulin-like growth factor is a problem. Everything becomes bigger in this patient, right? There are three classical syndromes of Wilms: WAGR, Dennis Dash, and Beckwith-Wiedemann, right? Microscopy, triphasic. There are three phases: epithelial, blastemal, stromal. Epithelial will have ducts, tubules. Blastemal is small round blue cells. As usual, every blastoma will have small round blue cell. Stroma is just the parenchyma, that's all. I call something as an anaplastic Wilms if more than 5% of the tumor has high NC ratio, pleomorphism, and random things. When it's anaplastic, TP53 mutation is there and it carries a poor prognosis. Fine. Okay. That's about Wilms. Last but not least, there's a condition called nephrogenic rest. If that is positive in the next kidney also can have Wilms because a precursor of Wilms. Fine. Okay. I'm zooming out. This gives all the important things with respect to your renal tumors. Any doubt? Do let me know. Yes, no, maybe. So we have seen quite a few things with respect to your kidney chapter, right? We started with nephritic, nephrotic. We went through PSGN, MGN, Goodpasture, minimal chain disease, IgA nephropathy, RPGN, your FSGS. We saw all the glomerulonephritis. We saw diabetes, hypertensive kidney. We saw renal tumors. We saw renal stones. We saw the cystic kidney disease, right? What is neural test? Nephrogenic. Okay. Nephrogenic rest. It's a kidney tumor, right? Nephrogenic rest is like a precursor of Wilms. If the nephrogenic rest is positive in the non-tumorous part of the kidney, which means the other kidney also will have a cancer. Okay. Clear there, Mr.? Fine. Perfect. So we have seen quite a few things which were required from the kidney perspective, right? So now let's go to two important things with respect to your male genital system. Male genital system might not have a long answer for sure. Unless your examiner is very sadistic to ask a prostatic carcinoma in a long answer, they're not going to ask. But BPH can come in a slide and a viva, so that we have to know something about it to talk. Prostatic carcinoma can definitely come in a 5 mark. Testicular cancer, again, very unlikely to ask in a 5 mark, 2 marks, 3 marks. Seminoma might come in an exam, fine? Okay, now look at BPH. First of all, BPH is benign prostatic hyperplasia or hypertrophy, still in confusion. Different books call different things. The way we report is, we call it benign prostatic tissue. I don't care it's hyperplasia or hypertrophy. It's benign prostatic tissue, that's all. It's benign, that's more than enough for me, right? Okay, so here, the most important thing is, we always say that if it's hyperplasia, they progress to cancer. BPH is one hyperplasia which might not progress to a cancer. Remember, it's important for us to know that, fine? Okay. Central transition zone is where I can see hyperplasia most commonly. Peripheral zone of the prostate is where we see cancers most commonly. Transformation zone is the area of BPH, right? So what happens? What is the most important thing about BPH or the risk factor or the etiology is age. Age is one of the important risk factors of BPH. A man over 50, 60 years old, there is a very likely chance he can develop benign prostatic hyperplasia. The second important thing is westernized diet. When I say Western diet, diet high in carbonated foods, sugar, fat, processed foods primarily. Because a bit of an obese individual with age, definitely there's a risk of BPH. We'll see why. Normally what happens is, see, in a normal prostate, I have a very tight control between my growth and my death of the cells, so that it will not increase or decrease. Growth is regulated, right? So here, IGF, which is by default determined by your testosterone and a product of testosterone called as dihydrotestosterone. This drives the epithelial division. Whenever epithelial divides more than required, I'll have a negative feedback. TGF beta will elevate, TGF beta will suppress the growth. So it's always kept in a common thing. When IGF is more, because of testosterone DHT, epithelium divides. When the division is more, negative feedback comes, TGF comes, growth is regulated. With age, the amount of dihydrotestosterone increases. With more of fat and westernized diet and trans fat, everything accumulating, estrogen tilts the balance. Estrogen tilts the balance. So what happens is, the negative feedback will not work and more cells start dividing. Not just epithelium, stroma also start dividing. So age and the Western diet, which increases the adipose tissue. Adipose tissue by default, you know that, increases the estrogen amount. Men also have estrogen, very, very tiny quantities. But more fat we have, more estrogen we have. That's going to cause your BPH, right? Perfect. So clinical feature is the urinary change. What happens is, you'll have urgencies, you'll have dribbling of urine, more frequencies, and also there's an increased risk of infection. Because of stasis, there's increased risk of infection. Anything above 50 years with these features, think of BPH. Per rectal examination, you can feel the prostate is nodular. An ultrasonogram can definitely help us to identify. How do you treat? We use a surgery called TURP, transurethral resection of prostate. What I see in microscopy, and how do I differentiate? It's not a cancer. Remember, prostate and breast parenchyma. These are the two places where you have dual layering. That's very, very important. So you'll have normal epithelial layer, cuboidal or columnar, and a surrounding myoepithelial layer. This is benign. The moment you see two layers in a prostate, it is a benign gland. The moment you see two layers in a breast parenchyma, it's a benign gland. The moment myoepithelial layer is gone, it's malignancy. There will be no pleomorphism, nothing will be there, right? Two layers are present in breast and prostate, it's always benign, never ever forget it. And corpora amylacia, though not a classical finding, when you see corpora amylacia, that is secretions, you must have read in your first year, right? Secretions between the prostate gland, that's a classical finding for your benign secretion. Might be rarely seen in malignancy, but predominantly benign, fine? Himant, I'll ask them, it should be in the MedAdap in the FARRE batch, fine? Okay, that's about BPH. We know the etiopathogenesis, clinical feature, examination, microscopy, and treatment, okay? There'll be both increase in glands as well as stroma and BPH, fine? Now, let's look at prostatic adenocarcinoma. Prostate can have multiple types of cancer, but by default, the common guy is prostatic adenocarcinoma. Age is still the predominant risk, and a Western diet with high fat, red meat, and all of them, okay? And androgen receptor mutation can also add to the problem. Age is definitely an important risk factor in prostatic adenocarcinoma also, fine? So what happens is, we have an adenoma carcinoma sequence. We had the same sequence for colon. Most of the cancers have adenoma carcinoma sequence, right? So if there are few germline mutations like MYC, which makes the prostatic epithelium at risk, this might not also be there. Most of them are sporadic without even germline mutation. But the starting point will be this: a translocation between temporous and ETS. This translocation makes the normal prostatic epithelium a pin. Pin is prostatic intraepithelial neoplasia, like your carcinoma in situ. Basement membrane is intact, not breach. Exactly carcinoma in situ, right? And the moment the next gene goes away, that is P27 is lost, you'll end up in having a prostatic adenocarcinoma where you'll have invasion. It'll invade and go to it. P63 is positive in case of basal layer. You are absolutely right, Dharmishta. That's one of the markers for the basal layer, both your breast as well as in your prostate. Fine? Okay, great. So once it becomes a prostatic adenocarcinoma, it will definitely metastasize. And for metastasis, we need more gene mutation, which is P10 and most likely telomerase. And one of the common place where prostate can undergo metastasis is your vertebral column. And you know that you must have read in anatomy Bateson's plexus. From that, automatically it can go to the vertebral column. Fine? Okay? Now, how do I diagnose them? History will be like BPH. You will have a history of frequency, urgency, because there's a tumor which is compressing the urethra, that's all. PSA is a tumor marker which can be very highly elevated, but obviously tumor marker will have false negative and false positivity. Fine? It's not specific, but it's a very good marker. So what I see in microscopy, adenocarcinoma will have glands, 4 feet of dysplasia, and invasion. Invasion in prostate and breast, same, which is equivalent to loss of myoepithelial layer. The moment myoepithelial layer is gone, dual lining is gone, it is malignant. 2 markers, PSA everyone knows. That's again a not specific marker. Please remember AMACR. AMACR is more specific for malignant prostatic glands and not benign prostatic glands. And like Dharmishta said, I can use P63, not 53, 63, right? This should be negative, which means there is no myoepithelial layer, so it is malignant glands by default. Okay? Can anyone name the scoring system of prostatic tumors? I'm sure you must have read the scoring system. What is the scoring system for prostatic tumors? Anything which comes to your mind. Scoring system of prostatic tumors has been asked in few of the universities. Though difficult question for undergraduate, know little bit about it. We have a scoring system called as Gleason scoring system. Even if they don't ask in a essay question or a 5-mark question, they might ask in a Viva, right? So Gleason is a scoring system. Gleason has 3 things. First is Gleason's pattern. Next is Gleason's scoring. Next is Gleason grade groups. The final thing, what I report is Gleason grade group. There are 3 patterns. Score is adding the patterns. Groups are 5 groups. Fine? Perfect. It's Gleason scoring, right? So simple. If you have very well-formed glands and space between the glands, pattern 3. Cribriform, cookie cutter, Swiss cheese. They are gland only, like not exactly gland, fused glands, pattern 4. Sheets of cells or completely necrosis, pattern 5. Okay. Now, every biopsy, I categorize them into primary pattern and secondary pattern. Primary pattern is the most common pattern. Secondary pattern is the worst pattern. Okay, most high grade pattern. I am talking about Gleason of the latest one. Robbins has Gleason of 10 years old. Don't go with that. Okay. If I have only one pattern in the entire biopsy, I double the score. If you have two patterns, I add pattern, the primary pattern and the secondary pattern score, right? I'll give you an example. You tell me. The entire biopsy is made of glands, well-formed glands. Can anyone give me the pattern here? 3, 4 or 5? The pattern is entire is having well-formed glands. Pattern is 3, right? Only pattern 3. So how do you score? If there's only one score, we double it. 3 plus 3 equal to 6. Done? Second example. I have in a biopsy, like 80% of the biopsy is having cribriform pattern. And rest are having glands. What is the primary pattern here? 80% of the biopsy is having cribriform pattern and the rest are having glands. What is the primary pattern? Primary pattern is always the most common pattern, which is pattern 4. What's the secondary pattern? Well-formed glands is the secondary pattern, which is pattern 3. It is 7. This 4 plus 3 is also important because 3 plus 4 is different group, 4 plus 3 is different group. Okay? 4 plus 3 is equal to 7 is my score. Based on the score, we have grade groups. Grade group 1 is score 6, 3 plus 3, the best prognosis. If it is 3 plus 4, 7, it is grade group 2. If it is 4 plus 3, 7, it is grade group 3. Why this classification is? In the second group, majority is low grade pattern of 3. In the third group, majority is high grade pattern of 4. That's why we have change in the prognosis. Grade group 5, grade group 4, anything of 8. 4 plus 4, 5 plus 3, 3 plus 4, 5 doesn't matter. Anything 8, grade group 4. Anything 9 or 10, grade group 5, right? And the prognosis becomes worse as the grade groups becomes better. Fine. Okay. I'm zooming out a little bit. Gleason's patterns 3, 4 and 5. Well-formed glands, cribriform glands, solid areas. Primary is the most common. Secondary is the worst of lot. If only one pattern is there, double the score. If there are two patterns, calculate the primary and add the secondary pattern score. And based on that, we divide them into grade groups and then we give the answer. This is how we report Gleason. Gleason is a way of reporting prostatic carcinomas. Most of the pathologists who report do it on a day-to-day basis. So that is easy for them. But for you, it might be a bit confusing. Just look at this the day before the exam. You will recap things and you can write in the exam. Fine. Okay. Now, last but not least, let's have a look at testicular tumors. Ready? One of the testicular tumor which is there near CBMA curriculum is seminoma. If you know about seminoma, I don't know, your good lots of NMC says that, okay, you're amazing to go and venture into third year, right? So we'll also stick to seminoma. Other things are a bit rare. When you go to your surgery and gynecology, you'll read more of germ cell tumors. You'll read there, right? Recently, germ cell tumors has a different classification. We use the term GCNIS, which is germ cell neoplasia in situ. There are tumors which develop from germ cell neoplasia in situ. There are tumors which are unrelated to germ cell neoplasia in situ. We look at the unrelated ones first. Spermatocytic tumor, teratoma prepubertal, yolk sac prepubertal, teratoma and yolk sac prepubertal. If the age is prepubertal, it is not related to in situ. We'll see why very, very soon. A prepubertal tumor cannot be related to germ cell neoplasia in situ. Rest everything. Embryonal, yolk sac, postpubertal, teratoma postpubertal, anything postpubertal can be related to germ cell neoplasia in situ. all the germ cell tumors or mixed germ cell tumor or classical seminoma. Seminoma as well as non-seminomatous can be in germ cell neoplasia in situ, and I have non-invasive guide, that is in situ cancers. We divide non-invasive, seminoma, non-seminomatous with germ cell neoplasia in situ, and non-seminomatous without germ cell neoplasia in situ. Easiest way to remember is age. Pre-pubertal, no in situ. Post-pubertal, in situ is there, right? Now, let's look at the prognosis, pathogenesis. Before that, can anyone tell me any one risk factor you know for testicular tumors? Any one risk factor? Any one risk factor you know for testicular tumors? Whatever comes to your mind. One of the important risk factors for testicular tumor is cryptorchidism, right? It's a very important risk factor for testicular tumors. Just give me a second, guys. Sorry, fine. Undescended testis, cryptorchidism is one of the important risk factors for testicular tumors. Okay, perfect. So when you have an undescended testis or an environmental exposure to carcinogen from the mother is having an environmental exposure to pesticide, that's important, or a germ cell mutation of KIT. So what happens is, all this is going to affect the fetus. Let's say if there's a boy child, when he is in utero or immediately after birth, is going to affect them. So what I'm going to have? I'm going to have a mutated cell. A germ cell is going to get mutated. But you all know for a fact, in men, germ cells are always resting till puberty. They have an arrest in differentiation. So I have a mutated cell, but this cell cannot divide. It cannot cause cancer, right? It can never cause cancer, right? After maybe some time, one more KIT mutation happens. Fine. After that also, I cannot grow much. I can grow a little bit. Only after mutation, it can have an exponential growth, because only after mutation, spermatogenesis testis gets good amount of growth factors. Second mutation happens, still it will remain very dormant till puberty. After puberty, you have an isochromosome 12p. That is a very, very important condition that converts them into a cancer. Okay. Till puberty, it will remain dormant. That is the reason pre-pubertal tumors cannot have this pathogenesis. Post-pubertal, I have a mutation, arrested division, I have more mutation, I can become in situ. I cannot become cancer, no growth for me for becoming cancer. Then the moment puberty comes, in and around puberty, you have this common isochromosome which flips everything to become a cancer. So all post-pubertal tumors will have GCINS. Pre-pubertal tumors will not have this. Different pathogenesis, different outcomes. And this is common. Pre-pubertal, post-pubertal is common. Pre-pubertal is not common. Fine. Okay. Let's go to seminoma. Seminoma is a most common malignant tumor in testis. Germ cell tumor in testis. 20 to 40 years of age. This has a very classical appearance. Fleshy, homogeneous. They say cut potato appearance. I don't know if it looks like a potato, but fleshy and homogeneous is classical finding for seminoma. Seminoma's counterpart in ovaries, dysgerminoma. Fine. How do I diagnose seminoma clinically? A painless testicular mass and an ultrasonogram detects a tumor. Then I'll say, okay, it's most likely a tumor. You can do an LDH to tell the size of the tumor. Alpha fetoprotein only in non-seminomatous, beta HCG in choriocarcinoma. These are 3 available tumor markers. Fine. And also remember, 15% of the seminomas can have elevated beta HCG, not diagnostic, is a marker, that's all. Because 15% will have syncytial trophoblast. Fine. So what I see in microscopy of seminoma, nests of tumor cells and have septa, and the septa will have lymphocytes. Everything is classical here. Fibrous septa of lymphocytes is diagnostic. Clear tumor cells because they have glycogen in them. Okay. And these are PS positive because obviously glycogen is going to be PS positive. Fine. There is a reasoning why question here. Can I do FNAC or biopsy for a testicular tumors? Hi Ahmed. Yes, no, maybe. Tell me. Can we do FNAC or biopsy for testicular tumors? Can we do FNAC or biopsy for testicular tumors? No, we can't. right? That why should not we do FNAC or biopsy for testicular tumors? Because the answer is not very simple. It's not just the needle tract spread, right? There's one more important thing apart from needle tract spread, right? So no FNAC, no biopsy for testicular tumors. The reason is, yes, partly due to needle tract spread. Okay. It's not complete needle tract spread, plus one more important thing. Because testis is an abdomen organ. Testis is not coming from the external genitalia. It comes from the abdomen. It descends into your scrotum, right? Let's assume this is scrotal sac and you are doing an FNAC. The FNAC will allow the needle tract spread to the scrotum. From scrotum, it will go to the inguinal nodes because scrotum drainage is inguinal nodes, right? But normally, where will testis go? Normally, testis goes to pre or para-aortic group of nodes. Normally, testis does not drain to inguinal nodes. The reason why testicular FNAC is contraindicated is the needle tract changes the route of spread, or we use a term, it will increase the stage of the tumor. That's why it is not that's why it's contraindicated and why it's not done. Normally, it's from the testis to pre-para-aortic, but here testis to scrotum, scrotum to inguinal nodes changes the route of spread. That's why we don't do an FNAC. We do an FNAC for parotid. It can also have needle tract. No, we do FNAC for breast, but both goes to inguinal, both goes to cervical, right? So only I'm okay to do with this, but for testis, the route of spread changes. That's the reason it's contraindicated. Do remember then, a very good reasoning by question. Fine. Last but not least, spermatocytic tumor. Seminoma we read. So this was previously known as spermatocytic seminoma. We have changed the name because there's no relation to seminoma, right? It is a polymorphous triphasic germ cell tumor. It's spermatogenesis in excess. Imagine like that. Seen in 4th or 5th decade. Very rare tumor. Location seen only in testis, not anywhere. Like a spermatogenesis, I'll have small cells, I'll have medium-sized cells, I'll have giant cells. Like a spermatogonia, spermatocyte, we have multiple lineages in spermatogenesis. Like that, we have 3 types of cells. What is important is this pyreme chromatin, which is like the meiosis of spermatogenesis, the spermatocyte. That is very, very classical for spermatocytic tumor. Just remember the name pyreme chromatin. If it comes in a viva or an MCQ, where it is seen in spermatocytic tumor. Fine. Okay. That's all with respect to your main genital stem and kidney. I've got most of the things required. One of your friends asked me for penile cancers. I didn't include it for the only reason that penile cancer is almost equivalent to cervical cancer. We'll read cervical cancer tomorrow in the female genital tract. The only change is the organ, because gross, microscopy, etiology, almost everything is same there. Fine. Okay. Any doubts? Do let me know. If not, we'll call it a day. No doubt. Thank you guys. Thank you for your patient listening. See you tomorrow. We'll hopefully complete this systemic pathology tomorrow. We'll do female genital tract and breast. Most of the required things will complete. And after that, after a brief break, I'll come back with general pathology after some time. Fine. Thank you for your time. Have an amazing day.